Good morning, and thank you for joining us this morning. We'll take you through the quality improvement potential in joining the ASE ImageGuide Echo Registry, and I'll give you a brief outline of what this presentation will cover. So we'll talk about the idea of a registry in general, and then an imaging registry. You will learn about how that has developed by ASE. We'll talk about qualified clinical data registry concepts and some definitions. There is more details about these, but I do not want the presentation to delve deeply into these concepts. We'll try to make it very applicable to you. We'll show you how the two terms reporting rate and performance rate are obtained. And then we will go into those approved performance measures, and we will cover the performance measures under specific subtitles of significance, how to meet this measure, how the calculations of the performance rate, the reporting rates are obtained, the relevance for these, and then the feedback you would be getting from the registry once your data has been uploaded. And last but not least, how the quality of care can be improved by participation in the registry, not just for the physicians, but for the echocardiography lab team members. So for that, because part of the reasons for participating in the registry is to qualify for the merit incentive-based system. There is a background that would be a good idea for physicians in particular to look at. There has been a previous presentation present on ASE University and also on YouTube by my colleague, Dr. Jeff Rose, that talks about the principles of MACRA and MIPS. Also, there will be a dashboard walkthrough at the ASE Scientific Sessions in Portland this year. It is scheduled for June 23rd at 3:30 p.m. And on behalf of myself and the ASE team members and the registry committee, we look forward to seeing you in that session and show you how to work with the registry dashboard. And now let us talk about the registry overview. What is a registry? Each one of us is familiar with our own lab performance as lab directors and as lab managers. You can look at your numbers, how many echoes you do, how many are appropriate, and so on. With the registry, we are able to pull data, collect data from many labs all over the country, and then we are able to analyze it, and we can see a snap view of how the field is doing with respect to these measures that each lab has looked at for its own, but now we're looking at it for the whole country. We can say this gives us a good look at what is happening and therefore a good ability to see how we compare with others, be it in our region and different cities and different states. One can say, what is there for me to participate in the registry? Three good reasons. First and foremost is the quality. I want to know that what I am doing is pretty much similar or perhaps better than what the national average is. I want to know where I have deficiencies, because if I know that, I can improve them. And that's the whole idea also of CMS and reasons to join in these registries. The second reason is as the field grows, we are hearing about new technology that is being introduced. We are talking about additional acquisitions that sonographers are asked to do and physicians are asked to do more measurements. One can ask the question, is this important? How does that affect patient care? So it provides us for an opportunity of research, and there is a large potential to link the data that we acquire with what happens to patients down the line, be it for their measurement and ultimately their clinical outcomes. And last, with respect to reimbursement. ASE has looked at the idea of the registry over the past few years, and it was created to address the quality question in cardiovascular imaging. As early as 2005, many leaders in the field of cardiovascular imaging advocated for the creation of a multimodality imaging registry, wherein the cardiovascular community can participate, and then the data from the registry provides feedback to the clinicians about how their performance compares with benchmark data that could be used to stimulate quality improvement. Now we're talking about the ImageGuide registry. That's the trade name for our registry, for ASE registry. It is a joint collaboration between the American Society of Nuclear Cardiology and the American Society of Echocardiography. As you see, it's a broad scope of imaging, and it is user-friendly in the sense that there are two modules under the same ImageGuide registry, and if I'm a physician who reads echocardiography studies only, I would use the ImageGuide Echo module. If I am doing both and I interpret both nuclear imaging studies as well as echo studies, then I will have access to both modules. Now, talking about the echo module in particular. So we've been saying that this helps many individuals. The first people we've talked about are physicians and researchers in the previous slides, but this also extends to our patients and what they get out of getting an echocardiogram. If we perform better quality studies, if we are more compulsive in what we report and being clear in our findings and doing the tests on the correct patients, patients will benefit as well. At the present time, the ImageGuide Echo module collects transthoracic echocardiography information and stress echo information. So we have demographic information about patients. We look at the clinical indication. Whatever the lab enters as the clinical indication will be uploaded to the registry. We are able to look at the appropriate use criteria, which is very important, as you will see among the performance measures. We look at the views obtained, and on the reporting side, the standard reporting about ventricular size and function, left ventricle, right ventricle, also atrial sizes, left atrium, right atrium, comments on valve structure and function for the 4 valves, any comments entered about the pericardium and left ventricular diastolic function or filling pressure, and then all the measurements that a lab has done. If you've done linear measurements, we're collecting these. If you've done volumetric measurements for the different chambers, we are collecting these. If you're doing specific measurements for stenotic valves or regurgitant valves, these will also be collected. We will not decline a study upload if it's lacking quantitative measurements that are correct, but these quantitative measurements, as you will see, will factor into some of the performance rates calculations, and so it is preferable for a lab, if you've done these measurements, to include them. Talking now about the goals of the Echo module. First and foremost is the timely quality of care feedback. So physicians will get their performance in the light of what are the benchmarked values and use these data to see where they stand and improve where improvement is needed. It facilitates the fulfillment of regulatory and other reporting requirements based on what we see in terms of what new techniques are being performed, how frequently measurements are obtained and reported. We can inform health policy and, importantly, reimbursement advocacy. The registry is a strong platform for research and education, and certainly can drive the field of echocardiography by demonstrating the value of technology and opportunities where expansion is needed and possible. Important to emphasize that the data that are in the registry are owned by the physician community and will help each physician with respect to quality improvement efforts as well as reimbursement issues for the field in general that are useful for the lab as well. Later on, it will be linked to outcomes data, and these could be patient management, how patient management is altered, and then along with patient management, how the imaging data affects the ultimate outcome. The ASE Registry Committee is looking down the line at linking the report with the ultrasound images captured during the study, and as you can imagine, this opens widely opportunities for research, for accreditation data, and many other things. So what were the phases for implementation of the registry? The first stage, the first phase, was the site profile collection, the demographics, transthoracic echocardiographic study reporting, and performance measures development. The second phase is the stress echo module development, expansion of the data set as more labs join the registry, and the committee will be working on transesophageal echocardiography performance measures as well. This is where we are now. Later on, we will extend the registry utility to the pediatrics echocardiography community. Data will have accumulated more, and therefore we are looking at greater and greater potential for asking important questions and having more confidence in the answers we get for these questions. And in the future, the ultimate link to the outcomes, data, imaging, and additional technology expansion. Now let us talk about the 2019 performance measures overview. So the slide that you will see has a lot of concepts and definitions. More of that can be obtained by looking at the presentation of Dr. Rose, and also you will have a PDF document that you can glance through later on. So I'll touch briefly on some of the definitions and the terms that you hear. The first one is a quality payment program. What is a quality payment program? First step of first component of a quality payment program is the collection of data. Second step is the reporting of data. Third step is the feedback, which is very important for improvement, and then payment adjustments based on that. Another term that you have heard is the MIPS, Merit-Based Incentive Payment System. As you know, one way of showing quality and being rewarded for quality is participating in MIPS. And there are other reasons, obviously, for joining the registry beyond being recognized for MIPS or having met some of the MIPS requirements. A third term that we use frequently is QCDR, or Qualified Clinical Data Registry. And what that term simply means is that CMS, the Center for Medicare Services, has approved this particular registry as a registry operating in the business of improving healthcare quality. So many organizations can have their own registries, obviously in different fields, some in cardiovascular reasons, some none, some with imaging, some without imaging. And then a QCDR performance measure. This is a specific measure that is approved by CMS for the purpose of MIPS reporting. So there are other measures that can be obtained from the registry that are not necessarily approved for MIPS reporting, but are still useful for the lab to look at and analyze. Again, with the ultimate objective of improving their care. So even if I am a lab or I work in an institution that is not participating in MIPS, but in an alternative payment system, I still care about quality and I want to show the quality of the work I do. Now some QCDR performance measures definitions. What are the quality measures in a sense? The quality measures that are calculated are based on measures submitted from patient data across all payers. So this is not just Medicare data that is used to obtain these measures. They are designed to allow physicians the greatest flexibility to choose up to 6 measures for reporting requirements. So you will see that we have ASE ImageGuide Registry has many more performance measures that can be useful. But touching quickly about these quality measures and how they are created. For the registry committee to recommend a performance measure, first we look at what the guidelines say. Second, is there a clinical gap, meaning the guidelines say we should report, for example, ejection fraction by measurement in all patients who come to a lab. And then when we survey different labs, we see that this is happening in, say, only 30% of the labs. So there is a clear gap between what the guidelines say we should do and then what is being done. Also, the committee looks at measure harmonization, and what the intent of this measure harmonization is something that eases the burden on physicians who are participating in the registry to avoid duplicity. So the way something is defined by one organization will be defined along the similar lines by us. So there is no confusion and there is no extra burden on the physicians participating. In our situation, we are looking at measure harmonization with the American Society of Nuclear Cardiology performance measures, the multimodality measures, and you will see this clearly as we go through our slides. Last but not least, we go through discussions with CMS. So we present them with our rationales, the evidence of the clinical gap, and CMS is able to look at these and give us feedback on how they view the potential utility of this measure. Now we go to the CMS approval process. So all the different registries come up with their performance measures, and then CMS looks at these measures and says, yes, this is a good idea, or no, this is not a good idea. What are they looking at? First, they want to avoid standard of care measures. What that simply means is if this is the standard of care and everyone is doing it, there is no room for improvement there, because if all of us are doing the same thing everywhere, then there is no reason to say you would expect points from doing that. Example of something that is considered a standard of care, it's a standard of care that we all should report the age of the patient as part of our findings in the report. So I wouldn't get any points if my report contains the age of the subject. The best measures are those that are outcome oriented, meaning they are measures that can change how a patient is being managed. Example, we get someone with shortness of breath, the echo report goes with an ejection fraction of 30%, and this patient is not receiving the proper therapy for patients who are in heart failure with reduced ejection fraction. As a result of that report, the goal-directed medical therapy will be offered to this patient. So that's a good measure. There should be a large performance gap. We talked briefly about the idea of the performance gap, but simply stated, the majority of the labs should, even though they should do this particular measurement or image acquisition, they are not doing it. If the vast majority of labs are doing something, then the implications of including this as a measure is for very few labs, and that is not the goal of such measures being approved by CMS. They should be in alignment with current clinical guidelines. So we shouldn't come up with a measurement where there is no support for its use in the guidelines. And last but not least, again, we go back to the quality action. should not be a mere checklist of documentation, but there has to be a specific aspect of quality that applies to the patient care, be it with superior, clearer image definition, for example, the use of contrast agents in technically difficult study, or in providing a better assessment of a problem a patient has, as for example, calculating aortic valve area in someone with aortic stenosis. It's unique and not duplicative. Now let us talk about reporting rates and performance rates. You will see these as we go through the different measures in later slides. So I will take time with this slide to explain to you what is a reporting rate and what is a performance rate. The reporting rate is a percentage of patients' population examined by the performance measure. The way it is calculated, and all of this is done automatically, is based on knowing who met this particular measure, who didn't meet it, those who were excluded, divided by the total number of eligible patients. Example is the appropriate use criteria. Shown on this slide now, you see a vertical bar that shows you the registry aggregate, where the reporting rate is at 90, where the reporting rate is at 64% or 63%, and this particular lab is doing better at 67%. Performance rate is the percentage of the eligible population deemed to have met the performance measure, and here the numerator is those where the measure was met, divided by the total number of eligible patients minus those who were excluded. An example is shown here as well with the appropriate use criteria. Both rates are shown on the registry dashboard. So now what are the measures, ImageGuide Echo measures at a glance? They include 14 measures for echocardiography, 4 transthoracic measures, 11 stress echo measures, 6 multimodality measures, 2 multistrata measures, meaning you can meet this measure based on several subcomponents, so to speak, of the measure. There is 1 transthoracic measure with 5 strata and 1 stress echo measure with 2 strata. And of those echo measures, 10 have received a high priority designation. On this and the following slides, you will see multimodality QCDR measures. Multimodality in the sense that the measure applies both to myocardial perfusion imaging as well as stress echocardiography. IGR stands for the ImageGuide Registry. So we have these measures numbered as you see. One of them is looking at whether the studies meet appropriate use criteria. If I am a lab that does stress perfusion imaging, but I'm not doing stress echo, then I can use this measure for myocardial perfusion imaging. If it's only stress echo, then I can use it for stress echo. Another measure is looking at reports that are clearly reporting something normal or abnormal, not sending a report that says not sure what is going on. A third measure applies to myocardial perfusion imaging, transthoracic echo, and stress echo, where left ventricular ejection fraction is reported. Here we are talking about quantified ejection fraction, measured ejection fraction, not a visual estimate. Another measure is the SPECT myocardial perfusion imaging or stress echo imaging protocol selection for morbidly obese patients. We have to tailor the imaging protocol to the need of the particular patient, so we will delve into that in some detail, and was that done or not done. IGR 7 applies to myocardial perfusion imaging or stress echo imaging studies with adequate exercise testing performed. We will present the rationale behind that in the coming slides. And measure 8 applies for SPECT myocardial perfusion imaging or stress echo utilization of exercise as the stressor agent as opposed to pharmacologic stress. These are the transthoracic specific QCDR measures. The first one is the comprehensive transthoracic study that reports a measured value of left ventricular ejection fraction as well as wall motion findings with an ejection fraction less than 50%. So if a report is reading an EF, say 45%, then we look at that report and see if it has a component that says there is regional dysfunction or global dysfunction, and then was that 45% obtained by measurements or not. For transthoracic echo performance per guidelines, that's the second measure that includes multiple strata, and you see these on the slide. The percentage of transthoracic studies reporting 100% acquisition of all the required views, the percentage of studies that was poor or technically difficult, and as a result, the endocardial border enhancing agents were used. The third stratum is the percentage of studies where pulmonary artery systolic or diastolic pressures were reported. The fourth one is percentage of transthoracic studies reporting on diastolic function in patients referred with shortness of breath or heart failure. The fifth one, percentage of transthoracic studies reporting on cardiac function using strain analysis in patients receiving chemotherapy. The overall performance will be calculated using a weighted average. You will see a slide where we take you through the actual calculation as an example. Then we have another measure looking at transthoracic studies meeting appropriate use criteria. With respect to stress echo specific QCDR measures, we have two measures. One of them is looking at parameters in dobutamine testing for patients with low flow, low gradient aortic stenosis. The other measure is looking at stress echo performance in patients with shortness of breath referred for a stress echo. This is a multi-strata measure, and it consists of two components. The first one, stress echo performed with an indication of unexplained dyspnea. That includes an interpretation of LV diastolic parameters with exercise. The second one, the percentage of stress echo studies with significant aortic or mitral valve regurgitation, and we're looking at how these components change with exercise. Again, the overall performance is being calculated using a weighted average. So now we deep dive into the measures. Let's start with the multimodality measures. The first one is the issue of using appropriate use criteria, and the whole idea is that we want to perform stress testing on patients who would benefit from stress testing, whereby stress testing can influence their care. How to meet this measure? The actual indication should fall into the category of appropriate or maybe appropriate indication. And so when we look at the calculation of the performance rate, we are looking at all instances of stress nuclear or stress echo. So we'll talk about stress echo now. Say we have 100 patients referred to a lab with the indication for a stress echo. And of those 100 patients, 80 cases met appropriate or maybe appropriate use indications, then this lab has a performance measure of 80%. If you look at what you would get out from the registry, so in this particular example, we are interested in the performance rate of this lab. The vertical bar that you see here is the registry aggregate, and you see it is a 94.5%. So of all the labs that have joined, all the physicians that have joined the registry, 94.5% of them have studies where the indication was appropriate or maybe appropriate. For this particular physician, this is where they stand at 79%. So this is less than that registry aggregate, and it's appearing in red, telling them pay attention to this situation. Another measure is the situation where the imaging studies were not equivocal. So there was a clear conclusion, it's normal or an abnormal test. The idea is that if a patient is referred for a stress test and the stress test comes back not diagnostic, the physician will have to do something else. Also, the treatment of this patient may be delayed, neither of which is something that is good for patient care. And so the way we calculate this measure is we look at all instances. Again, it's a combined measure. So it could be myocardial perfusion imaging or stress echocardiography imaging study performed on patients 18 years of age or older. And we look at the number of denominator eligible studies where the results were not equivocal. If we look at the registry aggregate, in this case, it's 63%. And the performance rate of this particular physician is better than the aggregate at 67%. Another of the multimodality measures is the quantification of ejection fraction. Lower rates of calculated ejection fraction can lead to lower quality of care. There can be situations where the visual interpretation, particularly with suboptimal studies or with less experienced physicians, is inaccurate. And as you can imagine, this can deny patients medications that would help them, or on the opposite, result in patients receiving medications that are not indicated and exposing them to their side effects. How to meet this measure? The registry will look for the ejection fraction calculated by 2D imaging, either from a single plane, biplane, or 3D. LV ejection fraction, any of these will be accepted. As you would expect, 2D single plane would be most accurate in patients without segmental dysfunction. How to calculate the measure? The numerator includes all the eligible studies where the left ventricular ejection fraction was calculated and reported, and the denominator includes, say it's a stress echo measure, all stress echo studies which were done in that particular lab. The example shown below is the registry aggregate here at that vertical bar is 6%, and this lab is having a good performance rate relative to that registry aggregate at 50%. Another measure is the imaging of patients who are morbidly obese. The significance is that we care for imaging tailored to the need of the particular patient, as opposed to using the same approach to all individuals, which may result in suboptimal imaging and therefore data that is either not good for analysis and thus not analyzed, or analyzed and leads to wrong values, which can affect patient care. The definition of morbidly obese is a body mass index more than 40 kilograms per meter squared. For echocardiography, we look at this body mass index and whether the contrast agents were utilized or not. And I will limit the discussion of this to just stress echo as opposed to nuclear imaging, though as you see on the slide, it is possible to meet this requirement as well for nuclear imaging. So the number of stress echo studies where contrast was used. Here, the denominator includes the number of patients who are morbidly obese who are referred to the lab. So in my lab, for example, I have 80 cases who are morbidly obese, and I used contrast in 20 cases only of these 80, so the rate is 25%. Let's look at the example shown here for this particular physician. The registry aggregate is at 53% or so, and this physician, with respect to the use of contrast in morbidly obese patients, has a performance rate of 74%. Another multimodality measure is the use of adequate exercise testing. The idea behind this metric is that if a patient is exercising but does not reach at least 85% of the age predicted maximum heart rate, the sensitivity of the test may be lower. And so if there is disease, it would not be picked. How will that be judged? This is based on reaching 85% of their age predicted heart rate, and it's 220 minus their age in years, and looking for an exercise duration of at least 3 minutes. So a test that meets these two components on someone referred for an exercise test would have met that metric. Let us look at the example here. The registry aggregate is 12%, and this particular physician stands at 20%. Notice we are just saying how that physician compares to the registry aggregate. We are not talking about whether that will be recognized or how it will be recognized for the objective of MIPS requirements. Another multimodality measure is using exercise as a stressor. Exercise by itself provides valuable diagnostic and prognostic information on top of the imaging data that we gather. And so whenever possible, the recommendation is to do exercise stress testing on patients who are able to exercise. In this particular situation, we cannot take all patients referred for a lab or who underwent a stress echo as the denominator, because in patients with a left bundle branch block, a pacemaker, or who are unable to exercise, these may not be ideal candidates. The numerator are the number of denominator eligible studies performed where the stress test type includes exercise. And again, the registry aggregate shown in the example below is at 31%, and the physician's performance is 85%. Now let us talk about TTE-focused measures. The first one of them is looking at patients where the ejection fraction is reduced, and we're looking at how the lab handled that. First, it should have measured the ejection fraction, 2D single plane, 2D biplane, or 3D imaging, plus it's reporting wall motion. The idea is, say this is a new finding for a patient and the report goes with wall motion abnormalities, this will heighten the suspicion of coronary artery disease and can trigger additional workup. How it is calculated, it's the number of denominator eligible studies where both components are met, the quantified ejection fraction plus the wall motion findings. The denominator is the number of comprehensive transthoracic echocardiography studies with an EF of less than 50% on patients at least 18 years of age. Example of the calculation is shown here. So there is the situation where 82 patients had transthoracic imaging. Of these 82, 75 had an EF less than 50%. Then we look at those 75 cases. How many of them ended up having a measured EF and a comment on wall motion? If it's 15 out of 75, then we're looking at a performance rate of 20%. How did this physician compare with the registry aggregate? The registry aggregate stands at 12%, and this physician is doing better, 20%. While 20% is better than the aggregate, clearly there is a lot of room for improvement for this particular physician. Now let us look at the transthoracic performance measure per ASE guidelines. They apply to all patients who are at least 18 years of age or older. It is multi-strata. One of these is 100% attainment of required views. The second one, the use of contrast in patients where the study quality was poor or technically difficult. A third one, reporting of pulmonary artery pressures. A fourth one, diastolic function in patients with shortness of breath or heart failure as the indication. The fifth one, cardiac function analyzed using strain in patients receiving chemotherapy. You will see an example on the next slide showing how it is calculated, but I want to emphasize it's a weighted average that looks at each of these 5 strata, and you do not have to have numbers in all of these 5. You will not be penalized if you're not able to report on all of these 5 strata. This slide shows the calculation with respect to numerator and denominator for each of these strata. We've touched on that briefly. The first one is 100% of the views. That's an expectation for all studies, unless you're looking at a situation where the requesting physician requested a limited echocardiogram, in which case, or a technically difficult patient, in which case either there was no need to do the complete 100% of the views, or it was technically difficult to get all of them. The second one, the denominator, is looking at patients where the study was deemed to be technically difficult or poor, depending on the terminology used by the lab. The third one, again, applies to all comers cases of comprehensive transthoracic studies where a pulmonary artery pressure is included in the report. So all comers. Here again, we exclude limited, say, 2D studies. We exclude suboptimal imaging studies, patients who are, say, no, we don't have their age, so we can say that they met that piece of the age requirement. Diastolic function commence or LV filling pressure commence, recommended in individuals referred to the lab for heart failure or being evaluated for shortness of breath. So the denominator will look at patients with these indications only. And then we see how many of these there was a report on diastolic function. The last item is chemotherapy, similar to the first one on this slide, that is the diastolic function analogy. We are looking at cases referred with a chemo indication, and then we see how many of these had strain analysis. And that's an example with several numbers that you see here. So in this situation, this lab had 70 studies, which were possible to look at to see how many had 100% attainment of the required views. So after we exclude the different studies, say the limited 2D, the suboptimal studies, we are left with 62. Then we go to these 62 studies and we see how many had all of their views, 100% of the views obtained. So the performance rate here calculates at 87%. When we look at the category of technically difficult studies or poor quality studies, we have 51. And after we exclude patients where it was just a very limited exam or we don't have their age, say, for example, verified, then we have 47 studies, and we now look at how many of the 47 received contrast, so it's 43 of 47. The story with the pulmonary artery pressures, it's 70 cases. We say exclude the limited 2D where no Doppler was used, so we have 62, and we see here the performance rate at 27%. Diastolic function, we have 15 cases where the indication was shortness of breath or heart failure. After we exclude 3 studies because they were limited to D and Doppler was not obtained, we have 12 cases. Then we go to the 12 cases and we ask the question, how many of these had diastolic parameters or filling pressure reported? It's only 8 of the 12. And finally, the chemo indication, we have 12 cases referred, and we excluded 1 case because, say, the was a limited 2D for whatever reason. The physician didn't require strain to be performed, so we have 11, and of the 11, we ask the question how many strain was performed, and it was 7. And then when you add these numbers up, you come up with the aggregate rate. So we have a reporting rate of 89% and a performance rate of 67%. And that's an example for a breakdown across each of these. I will skip through this slide. So we talk about other measures. The next measure is our transthoracic studies meeting the appropriate use criteria. So here, the number of transthoracic studies performed in this particular lab is the denominator, and then the numerator will ask the question how many of these studies in the denominator were deemed appropriate or may be appropriate. That will give us the performance rate. And in this particular example, the registry aggregate is 63.5%, and this physician performance stands at 67%. While better than the aggregate, still considerable room for improvement. Now let us talk about the stress echo focused measures. The first of these is the use of echocardiographic parameters that are included in the report in patients referred with low flow, low gradient aortic stenosis and who get infusion of dobutamine to assess the aortic stenosis severity as the flow is increased through the valve. How to meet this measure? To meet this measure, we're looking at the quantitative measurements that were obtained at baseline and at peak drug infusion for those with known or suspected aortic stenosis. The numerator includes what you would automatically or routinely do in your cases of aortic stenosis, of LV outflow tract diameter, time velocity integral, aortic velocities, gradients, valve area, index valve area, and we want to see how these measurements compare at baseline and as you give the dobutamine. And the addition of ejection fraction here is to be able to comment on contractile reserve as well, which can affect outcome of these patients. The denominator includes all studies with this particular indication. So assess low flow, low gradient AS in the setting of an EF less than 50% on subjects who are at least 18 years of age. When we look at this particular physician performance, the registry aggregate stands at a 94.5%, but this physician is falling short at 79%. The next stress echo performance measure has two components, it's a multi-strata measure, looking at stress echo performance for shortness of breath per ASE guidelines. And the recognition is some patients will have shortness of breath because of diastolic dysfunction and high filling pressures with exercise. Also, it is possible that patients have valvular heart disease, valvular regurgitation that gets worse with exercise, and so the identification of these cases can help their treatment. How to meet this measure? It is based again on a weighted average across each of the two strata. One or both strata can be reported, and there will be no penalty if one is able to report on one but not the other. The denominator for the unexplained dyspnea indication that includes an interpretation of LV diastolic function is the number of comprehensive exercise echocardiograms with an indication of unexplained dyspnea in someone who is at least 18 years of age. The numerator here is how many of those cases with that particular indication have a comment on diastolic function at rest and with exercise, and that includes either LV diastolic function or LV filling pressures. In addition, we want to see a pulmonary artery systolic pressure reported on with exercise. The second component that falls under this measure are patients with significant aortic or mitral valve disease. So here, the denominator includes the number of comprehensive exercise echocardiograms with an indication known or suspected aortic or mitral regurgitation, and then what happens to the regurgitation with exercise goes into the numerator. So we're looking to see a comment on the valve function at rest and a comment on what happens to this valve function with exercise. Example of the numbers are shown here. So we have 55 situations where stress echo was performed. Of these 55 studies, 46 fall into the indication of unexplained dyspnea. And then we ask the question of those 46, how many had an assessment of diastolic function? It's 44 of 46. The second situation, we're looking at 24 of these 23 had the indication of valvular regurgitation, and then we ask the question, how many had assessment of valvular regurgitation at rest and with exercise of those 23, and the rate here is 65. So the aggregate reporting rate is 87%, the aggregate performance rate is 86%. And that shows the performance feedback for the shortness of breath per ASE guidelines, that 85%. And when we look at the diastolic function parameters component for unexplained dyspnea, was it met or not, the registry stands at 12%, whereas this physician performance is at 20%. For the valve regurgitation, the registry aggregate in the example shown here is 53%, and the physician performance is 74%. So in conclusion, the performance measures are designed to provide meaningful feedback about quality to everyone who works in the lab. That includes clinicians, sonographers, administrators. They are guideline focused. As you can see, there are echo-specific performance measures. We believe this is an innovative format and we believe it is impactful to the field. I want to say that all ASE members have free access to ImageGuide Echo. I will now start answering some questions. We have about 8 minutes left, and we'll do as many as we can. I want to say that if we do not get to your questions, then we will reach out to you and still provide you with the answer. So the first question is, how is it determined who passes and who fails a measure? ASE does not make this determination. What happens is the data will be provided to CMS. CMS will look at this data and they will create a benchmark score reflective of the average national score for this particular measure. And then depending on where a particular physician stands relative to that determined average by the CMS, there would be either passing or not, or meeting the performance measure. So it makes good sense for us in general and for CMS as well, that when we're looking at measures where the performance rate is pretty high, 95%, for example, this is not a measure that ends up being selected here. So if 95% of the labs say are doing 100% of the views, and I am a lab that does 94%, nobody would want to be penalized and say, no, you did not meet that requirement because the average is 95 and you're doing 94%. So we're looking clearly for situations where the performance is less than 90%. We do not have specific numbers, as I just mentioned, but that's the philosophy behind how these pass-fail assignments or determinations are made. How do we calculate measures that are shared with nuclear? Notice that when we were showing these slides, they had the OR measure. So if I'm a lab that does nuclear only, I can meet this requirement by how I perform on the nuclear measures. Or if I do stress echo, then I can meet it based on the stress echo, and I would get that performance measure if I pass the benchmark recognized. So I don't have to be doing both. We are often asked about what are the sonographer's potentials to participate in the registry. The registry is for all members of the echocardiography team, and you would get more out of it if the whole lab is able to look at this data and utilize this data. So sonographers can have their own unique registry login, and they can access any information contained about their practice. But for each site, there is an individual who will be charged with creating logins and access permissions, and that could be granted, for example, to the technical manager or to lead sonographers, whereby they can access the registry data as we just spoke about it. Also, part of the data that we collect within the different fields is who's the sonographer who scanned and what credentials they would have or they have. We hope at a later date to look at sonographer-specific performance measures as well. An important question is how to submit data to the registry. Manual data entry is an option. We also have another option via certified software reporting vendors. This avoids the manual data entry with the extra time and the potential for errors that come from manual data entry, and would have really minimal impact on a workflow. As soon as a physician reads the study, the report will be transferred to the registry via that certified software vendor. Let us look at other questions. There is a lot. This is an important question. Also, there is a lot of overlap with IAC accreditation. Will this be coordinated or linked to minimize redundancies and workload? So there is certainly the potential with interaction with IAC. ASE as well as ESNIC are in the process of having discussions with IAC to see how we can help with the process of limiting redundancies and minimizing the workload on physicians. I would say some data may be useful for both. However, there are some unique aspects for accreditation that are not yet available for registry participants. Example, IAC has to review actual images. The registry as of now has not allowed yet image uploading. When that becomes available, then yes, one thing can serve for both purposes. Looking at meeting performance measures via the registry and then helping with the accreditation, reaccreditation process with IAC. We have a question next that says, this sounds like a lot of work. Who will do the work? Who will pay for the extra work? Let's talk about this. So if I am a lab and the vendor I use to generate my reports, my echo reports, gets certified via the registry, I don't do any work. That certified vendor will take care of what follows. And there will be no impact on workflow and no extra cost involved in this process. Participation in the ImageGuide registry is free for all ASE members. However, if there is a manual data entry decision, meaning for whatever reason the lab decides I want to do manual data entry, then yes, there will be an extra cost incurred there. But for joining the registry, there is no cost. So I would recommend that you work with your vendor that you use for generating the reports to get that vendor certified with us, and it's a smooth process, straightforward, and they would be submitting these reports on your behalf for free. Next question is, what type of reimbursement incentives are offered for completing this information? So these performance measures can count towards meeting the MIPS requirements and avoiding negative payment adjustments. However, I want to say, aside from the reimbursement issue, knowing where I stand, for example, with respect of getting 100% of the views and commenting on diastolic function in someone with heart failure and using contrast when the images are not of good quality, is a great opportunity for improvement. If I see where the national average is and where I stand, I would improve my performance. The next question is, are the data automatically extracted from the clinical reporting system of the participating center and transferred into the registry, or is the participating center required to type the information directly into the registry? So the certified vendor is the way to go and recommended. We have the option also of manual entry. How is an important question is next. How is the determination of appropriate use made? Is it off the limited indication on report, which is not specific or detailed enough to determine AUC? So the only way we can determine whether a study is appropriate, maybe appropriate, or rarely appropriate is based on the indication. So it is in the lab's best interest to have that data entered thoroughly and correctly. And aside from the issue of the registry, if I'm a physician looking at a study, I need to know the correct reason why a study is being done. What is there to obtain out of this study so that I can report it to the referring physician? So I would say the issue of the indication is a critical issue for proper patient care, and as you see, for the determination of whether this particular physician has met the measure of appropriate or maybe appropriate study. The next question, how does the data get from the lab into the registry? So either we have the manual data entry option, or we go to the certified vendor that will automatically use the report once finalized by the physician and transfer that to the registry, which would be the preferred way to save time and to avoid errors. Question, if I am an employed cardiologist, can I join the registry by myself, or I have to go through my employer being part of the registry? There has to be an agreement between the institution and the registry. The institution can enter in the negotiations after it has learned about what the physicians want. I see we are running out of time. I will just say one quick comment. This is, since there is no need for IRB approval to get this taken care of. We have many other questions, and we'll try to answer these and respond to each questioner. I thank you for joining us this morning, and I hope you have a pleasant afternoon, and looking forward to seeing you in Portland. Goodbye.